The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Physician Computer Company. PCC empowers independent pediatricians, streamlining daily operations and improving financial stability. A trusted pediatric partner for 40 years, we offer award-winning support, personalized training, seamless data transitions, and practice analytics. With inclusive pricing, a lively peer community, and a free annual users conference, you can focus on what matters the most, your patients. Explore more at pcc.com. That is pc.com. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Good morning, George. It's Tuesday morning and we're back on the line.
Good morning. It's Tuesday morning once again. And today we have a legend pediatrician, Dr. Susan Sirota. I've known Susan for many years. I've learned a lot from her. And the topic of discussion is something that we all know: implementing change in the pediatric office. And if you don't know about implementing change, you better learn, because you're going to go out of business.
Welcome to our distinguished guest, Dr. Susan Sirota, a dedicated pediatrician, esteemed teacher, successful business owner, and inspiring leader. She wears many hats with grace and tenacity. As a mother, Dr. Sirota brings a unique perspective to her work, understanding the needs and concerns of both children and parents. She is also known for a forward-thinking approach to medicine, being an early adopter of technology in the pediatric office. This has significantly enhanced her practice, using tech advancements to provide more efficient and effective care. Join us today as we deliver into her journey, exploring her multifaceted roles and her innovative use of technology in pediatrics. Welcome, Susan.
Thank you. It's really my pleasure to be here with you guys this morning.
It's such a joy right after Hanukkah and right before Christmas to see you.
Yeah, it's a busy time.
Yes. So before we get started with the show, you wear many hats. So you're a general pediatrician in Chicago. You also, I think, volunteer some with the medical school to teach residents and students. You lead a large specialty group in Chicago. What are we up to now? 75 clinicians?
Yeah, so we're single specialty. We're pediatrics. And yeah, we're between 70 and 80 clinicians. We have some joining and some retiring.
And that includes mental health specialists, lactation consultants, and also urgent care.
We have, yes, it's true. We have our after hours care and physicians employed there, as well as many of us as owners who work in our after hours care. We also have dietitian, integrated psychologists, and lactation services.
And in addition to that, your group has a standalone revenue cycle management company that's best in the industry.
That is true. So our practice is owner. So we spun off a billing company, essentially our own billers who are doing great. And so the practice itself has ownership, as well as some of the original owners in our merger practice.
Wow, that's a lot.
And I don't know if I can say names, but Spiro MD is our revenue cycle management company.
Yes, of course you can say names. We'll put it down in the show notes.
Yeah.
And you're a mother, is it to 3?
I have 3 children, teen and young adult, and all full-time students right now.
And you're all avid skiers.
Yep.
Yes, we are, as George knows.
And
I even had the pleasure of meeting one of my kids.
After saying all that, I need to take a nap. And I haven't even started the day.
Well, with all that you guys have going on, you must be prey to all these private equity companies and systems. There must be nothing on your door every other day.
Yeah, I don't know about Prey. I have to say there are absolutely many emails that come through the inbox there. We took the opportunity to entertain one potential, I would say potential opportunity that was presented to us through the unique channel. And I can tell you that it didn't take us long to figure out at all that at this point we are going to do best for our patients staying independent.
And they always say that the company that everybody wants to buy is a company that's worth keeping.
I like that. I like that.
Susan, why is it so difficult to implement change in a pediatric practice? They say it takes about 17 years from the point that we know we should do something different to the time that it actually starts being done in the offices.
That is true. I was actually doing some reading about looking online to see where the evidence was that came from. But yes, that is the number that's thrown out. But it's so difficult to make change as pediatricians because we're human and our brains hate change as humans. They hate change. And what our brains do instead of seeking change is they hang on to habits, right? And it's like this belief that what we've always done is going to continue to work. And brains hang on to those habits, even when the evidence says otherwise, this is not going to work. And with that, we all have, I think, experiences we can think of personally, but our daily lives are driven by habits. And those habits really deal with what we think of as like our low risk tasks, things that we do all day long that we don't even notice because it's just driven by our habits. And so if you think about pediatricians and pediatric practices, what we've done is we've created habits in our practices as pediatrician leaders or maybe individuals that started our own independent practices. Then we create a culture that's based on those habits. And we then hire people who align with that culture based on habits. And so what happens is that physician, pediatrician, and staff, we just go through our daily lives and our work in our offices relying on those habits. But there's, I think, more to it. And that's think about our training, right? Think about our training as physicians in medical school and just our training as pediatricians. Like we're educated and conditioned to minimize risk, right? That's a huge part of our training in pediatrics. So when you take all of those things together, it's really no wonder that it's incredibly hard for people to make change in their office.
That's why I have in my email signature, I don't know if you guys have ever read it, the most dangerous phrase in the medical practice language is, we've always done it this way.
Yeah, I was going to say, and that is exactly the sort of the momentum in our brains is to do exactly that. And you're absolutely right, George. Like it's dangerous. And I was actually I like to read about this because just because I'm interested in change doesn't mean everyone on my team, we have a big team, is always ready to come along. And we know that we're in a time where things are changing really rapidly. Generations ago, people lived basically the same life their entire existence. And one of the things I was reading about, and a term I really like, is that now that we're in this time where there's a lot of change and changes are coming more quickly all around us, but especially it's been that way for almost 4 years now since the start of the pandemic in pediatrics, is that what we need to do is rewire our brains. We have to retrain our brains. And someone by the name of Erica Anderson, who published in the Harvard Business Review, uses this term where she says, you know what, we need to become more change capable. We have to teach ourselves to be more change capable because the rate of change in medicine is coming so quickly that there's just no choice anymore but to adapt and change, or we're really not going to be able to keep up. And we may not be able to keep our businesses as practices. And we've seen that, right, already with some of our colleagues.
I guess that's the reason why they were bought out by systems. I remember when it was the time for the EHR, my senior physician, my senior partner, they were on paper for a million years. And I tried to introduce the idea of let's get an EHR. And he says, there's no way that in my lifetime you guys are going to get an EHR. So he was a roadblock to it.
Mm-hmm.
We tricked him into change into an EHR by getting some grant funding, somebody else to pay for the bill.
Mm-hmm.
Get that out of the equation. So he was part of it. And the poor guy ended up changing 2 EHRs. He went from Encounter Pro first, and they got bought out. Then he went to Office Practicum afterwards. So nothing to
Yeah.
do.
No, it's a lot. And if I could just go on a little bit, I think one of the things that's really interesting about change, and I know I use this most days in my practice because we're managing so much mental health, but this woman, Erica Anderson, who talks about helping make people change capable. She has this what's called this change arc, this proposed change arc, where you have to propose a change, then you have to shift your mindset. That brings new behaviors, and then the change occurs. And when I was reading that, I was thinking, this is the cognitive behavioral triangle we talk to patients about all the time, right? You have to change your thoughts. Your feelings will change about whatever the situation is if you change your thoughts, and that's going to drive a change in your behavior. So it is interesting to me that a lot of what we're asking and what it takes to change and be change capable is something that as pediatricians, we ask our patients to do all the time.
Yeah, the big problem there is that we're still reptilian brains, and the amygdala hijacks our behavior every day. And so that's to override our amygdala and not be scared of changing. That, in theory, I think is not a hard thing to do. But in practice, and especially I think pediatricians especially, we're very risk adverse.
Yeah.
We
Yeah.
don't want to try anything new on a child until the Pope and 3 other people have blessed it. Because we're afraid of what we don't know and what that could do to that growing brain and that growing body. And so that permeates everything that we think about is, first of all, don't change, don't do harm, keep it steady, and the children will grow up to be healthy. That doesn't work anymore in real life or in business. And it's, I
Right.
think, really hard. I tell parents today, I don't know how hard it is to raise a child today with how fast things are changing and the access to information that they have, the children. It's just a totally new world. It's invented every 18 months. So I think there are some basic principles when you're trying to implement change in the pediatric office. So let's try to dig a little deeper. I think as pediatricians, we don't want any change that doesn't improve care or the patient experience. Right?
Right. That is true. That is true. I am transitioning a bit in my own role, and as a larger practice, we have some big leadership transitions coming. And I really tried to spend some time learning. And I was introduced to a book that's called Managing Transitions. It's a great book. It's an easy read. It's William and Susan Bridges wrote this book, but it's a nice way to think about transitions and how to change. And I think one thing I want to point out is that sometimes in our practices, when we want to make a change, there's a lead physician or a managing partner. We're like, you know what? We should do this because it's a good idea, or we need to do this because this is how we're getting our value-based payments, or whatever is the motivator. And we say, we're going to do this, let's do it. And then we just want to hit the ground and run. And there's really a process to be successful with change because people don't want to change. And so they talk about this, just really resonates with me, like putting some structure around it, that the 4 Ps. So purpose, you need to have a reason, right? There has to be a purpose for making the change. You need to paint the picture for people. People need to be able to see in advance what that outcome is going to look like, what it's going to feel like for them. What is the picture? What are we going after? Let them know the plan. And then even down to that almost individual level, like what is their part in the change? And if you keep those 4 Ps in mind, then think of that as like the overall recipe. But then there's some really important ingredients. Effective communication is critical. You have to have support mechanisms for people. So you plan that this is going to be hard and have a way to support them through it. And then very specifically know what you're doing to alleviate the fears and the concern, because those are the things that really hold people back, whether they're worried about losing control, whether they need to stay in their comfort zone, whether they just lack understanding about what's going on because they haven't received enough information. That information has to be like over and over again. You can't just, tell people one time and expect it's going to happen. And then for a lot of people, when we make change, they have a perceived threat to either maybe their identity or their role in your practice or just their status, what it might mean for their job. When you think about making change and the fact that those you're asking to change are thinking about a loss, or maybe it's triggering other feelings from prior losses in their lives, you always can think about, but what can I give back that is going to balance what's lost, right? I think there's definitely some good strategies to do it. And I agree with you. If we can improve care, we can improve experience. That's really a great starting point as far as the first key, the purpose of what we're doing.
Yeah, because I would say almost all pediatricians in clinical practice are mission driven. So if you can show them this isn't going to improve the life of the children they take care of, at least you got the foot in the door about talking about what the change needs to be done.
And I'm someone, I like really practical advice. Like when I'm listening to your podcast or I'm going to a conference and getting educated, I want to feel like I can walk away. But that sounds like a great idea, but what exactly can I do? Or how do I do this? And I think one of the things I've learned is once you have that purpose and you want to create your plan, your process, and get to the place of change, something that is really important is figure out who are you going to get buy-in from? Who is really focused on your mission and who are all the stakeholders, right? Just because the doctors are going to do something differently, it might affect everyone. So if you can bring champions together from every area of the patient experience, and you as a group define the goals, and you as that group of champions creates the process, and it makes sense every step of the way because you've represented every step of the way, then you can train the rest of the team, bring them along and really have something that works. And I think it's important to take a step back and respect the process to also be successful with change. It's very hard to just show up on a Monday and say, you know what, this is a great idea. I want to do it in my practice. I heard about it. We're doing it. It never works. So just wanted to throw that out there.
I think what she's describing is the mindset that you have to have when you're changing your EHR or going from paper to EHR. All those buzzwords, champion, supporting, those are the things that were needed to have a successful EHR implementation.
And really any technology. The EHR is just one.
Yeah, that's a big one.
So the rub in does it make my patient's care better is that it is often very difficult to define what we're making better. And it's sometimes the data is very murky and you're trying to figure out, is this really good? Or is this really just the latest flavor of consultants as to what we need to change, or the latest tech company that's trying to sell you something that is not necessary and is not going to do anything. I think that's where you're going to find a lot of resistance on the clinical side of people saying, whether it's technology, a medicine, a new process, is really show me the data. How many people have done this? And does it really improve my patient's satisfaction with the clinical care we're giving them? Does it improve their lives? And does it not cost $2 million because they can't afford it?
Right. And sometimes what we can do, sometimes what I've done is I've connected with developers of different tools very early on when they're in their beta testing, for example, or even piloting for usability. And because you won't always, if you're ahead of the curve and you want to try something that's really new and innovative, the data won't be there. There may be a little information validating a tool so that it's out there and it even makes sense to use, but the data is not really there. But you can participate in the process of collecting the data, not just for the individual developing the technology, but really ask your patients, how was that for you? Was that easy to use? Was it hard to use? Ask your nurses or MAs, what did it feel like? Trying that with the patient, how did they respond to it? And then, of course, it's the physician, and to the questions I think that go along with change. Is this making sense for me? And does this make my day better and my patient's life better? Or is this a challenge? And I don't think it's worth it, right? Everything has to balance to feel like it's the right experience. So you can try it out. You can try it out and then decide, doesn't work for us, and move on.
And so when you're an early adopter, do you just do it in your office, in your pod, or before you roll it out system wide?
So we do a couple things. Like I like these things. I like trying. And so sometimes we do start in my office. Sometimes it's just me that starts with some of my nurses who are really into it too. But one of the things that we do try to do, because we have so many different sites in Pediatrust, is we sometimes try to find a handful of individuals in different locations, because just because we're part of one group, every office is not exactly the same. And our patient demographics are not identical site to site. And so by trying it out in a few different locations with a few individuals who are really open to change, we just tend to gather better information that way. Less bias, I would say, in what we gather.
Okay. And then you mentioned this, but if it doesn't increase efficiency and effectiveness to the care delivered by the physician, it is unlikely you're going to convince me to change my workflow.
Yeah. In many respects, you might say if it doesn't do that, it's no good. I think that is one of the most important points of evaluating a tool for change or some sort of change. So for me, that's a must, right? No one ever wants to transition to something, I don't think, if it doesn't meet those criteria.
And
I can think of a couple examples too of things that
the
there were
EHR,
no-goes.
the EHR doesn't improve efficiency when you're in the exam room. It may do a lot of other things system wide, but for the clinician in the exam room, it's more inefficient. And I think that's why it's universally unliked. But it is what it is. It does improve efficiency in other parts of the office.
And certainly like revenue cycle management and some of the other flows. But if you're balancing efficiency and effectiveness, there is a lot of upside, I think, on the effectiveness side. And I'm a big believer that we can keep building and innovating to figure out the efficiencies. We're at that breaking point in so many physicians, and it's tied to the EHR. It is necessary to make those changes for efficiencies. And I think finally, the companies that make them, I'm not employed, but employed individuals under healthcare systems, they're recognizing, maybe a little too late, but that they have to do something to help that efficiency.
We forgot, but in the old days, you had to pay a staff member to stay after hours and pull all the charts for all the physicals and all the sick appointments that were coming tomorrow.
Oh, yeah.
And
Oh,
you
how
know, I
about
mean,
the
people
camp?
forget that.
How about the camp forms in the summer? I used to come in on Sundays, and there would be stacks this high, right, of charts that someone pulled to then start going through to complete forms. That all just happens as soon as we do a visit now.
And then how about the
Yeah.
redundancy? Like just when you had paper, you had to write in the progress note that you gave the MMR and the varicella. Then you had to write it on the front of the chart so you can keep
Right.
a tally, because you could not read where all those people
Right. Right.
signed it. And then you also had
Yeah.
to circulate it on the super bill.
And
Yeah.
you had no scanner
And you had no
or
scanner.
barcode. So you
Yeah.
were like, where?
And
Yeah.
then many
I
offices
guess we're old.
had a staff member who did nothing but call patients to remind them about their appointment tomorrow.
Yep.
No automated emailing, no
Right.
automated dialer, no automated texter. It was
Right.
by one. There's 100 patients on the schedule. This person called 100 persons to remind them about their appointment tomorrow. But people forget because they don't, especially younger doctors, don't see that or haven't seen that. And so they don't know how much work that entails.
Oh, one more thing. How about when you had your asthmatic that you had to order a prescription for albuterol, Pulmicort, some steroids, maybe a Z-Pack? That's 4 prescriptions. You had to write the name 4 times. And then after you're done and you think then you had to write it in the chart too, right?
Yeah.
When you thought it's all over, oh, by the way, can you refill my child's multivitamins and then the brother and sister too? You want to like pull your hair out. Now it's like, sure, no problem. Boom, click, boom, click, boom. It expedites things.
Yeah,
Yeah.
that for sure. I was thinking, when we were talking about like efficiency and effectiveness, and I think I talked to both of you about this in the past, but just over a year ago, myself and several of my colleagues in our practice in Pediatrust, we're trained in using point of care ultrasound and have been using that over the past year. And lung poke is probably one of the best things for pediatrics. In fact, we're even thinking about within our own practice, just training people specifically on lung pocus. And it can really help you with, especially these kids we're seeing now, pneumonia, wheezing from the RSV, all of the respiratory viruses. But there's a challenge, right? It's a tool that's incredibly effective. It'll pick up pneumonias before X-ray. It will show you that lungs that don't sound so okay and kids are crying, that they're actually normal. But it does take time. It takes a little more time. And many of our doctors who see a lot of patients who are busy and are actually trained to do this and they know what to do, they'll forego doing it because it brings inefficiency to their day and their schedule when they're seeing so many sick kids, even though it's an incredibly effective tool to help us understand what's going on with patients. So for me, there are so many examples of technology beyond an EHR where we really have to figure out how we're going to work them in if they are a little less efficient because they are so incredibly effective.
But I've always used this.
Yeah, it's a better tool. It's that, honestly, I learned to keep it really close to the side of the office where we see sick visits. So I don't let transportation waste, walking all the way to my own office and coming back to this other side, be a reason not to do it. But it's just a better tool. And eventually we may do more of that instead of stethoscope, right? When it comes to the lungs, all of us.
And then I think another key principle when we're trying to change in the pediatric office, it has to lessen the burden on the physician and the repetitive stress. And right now, I use ECW in the clinic that I help on Fridays, and they put up this new screen that pops up when you write a prescription that tells you whether the pharmacy that you're sending the prescription in the health plan will cover this prescription or not. I don't really care. I don't have time. I got to go see the next patient. Don't pop that screen. That's what there's a pharmacist getting paid for. If you have whatever, here's Anthem has a Medicaid product. If Anthem doesn't have a contract with Walgreens, that's not my problem.
Yeah, but
You
they're
know?
going to call you.
No,
Just
they'll just send something and the staff takes care of it. I don't deal with it.
Yeah, but the staff's not going to know how to change the medicine. They're still going to come to you. So I have to disagree with you on that. With the formulary,
staff's pretty good because if you do that 30 times a day, it just delays you. At some point, people have to have ownership. If you know that your health plan is not contracting with Walgreens and you need to go to CVS, I don't have time to figure that out for 10 health plans and 15 pharmacies. You need to figure it out on your own.
We need a better, I don't have that. I have more what tier it is and it gives me an idea of which could be, but it's just a matter of picking one from another. But something like that makes me think about the insurance companies. And that's, as you said, between the insurance company and the patient or the family. In our case, why are they putting the work on us? This is exactly to your point. We need to lessen the burden on physicians. They have a deeper pocket. They have many more million and billion, I don't even know, employees than we have. Why is their system not using technology and repeatedly texting patients to say, we see you have an appointment today, right? Or you've scheduled an upcoming appointment, or your child is seeking care. You may only go to these pharmacies. Why are they not providing that information, right? Because they're hoping the patient will go somewhere. It's not covered, paid out of pocket. And then maybe it will be less of a cost than insurance will be. I don't know. Or maybe they're just not thinking about how to lessen the burden on us, which is probably more the reality. There's so many problems, right? That could have simple solutions with technology if we just had the right players thinking about how to do it and acknowledging that it was their role.
Yeah, it's funny. Sometimes it'll pop up, budesonide from Overhaul is not covered, but change it to Symbicort. I'm like, I'm not writing for a brand name only. That costs more money.
Yeah. It's the pharmacy benefits managers, right? Though
then I just scratch my head like, this is not my problem. I'm going to write for the generic version and they figure out which one they're going to dispense. Not my problem. So if it doesn't lessen the burden on the physician, it's going to be hard on that planning stage that you were talking about to get more people to buy in and get some champions. because the clinicians are going to say, no, I don't want more screen to pop up, especially if it's not that important to patient care. Let someone else do that.
Right. That's critical. To me, maybe not even critical. It's almost like existential, right? Because if we don't do this, we are at such a crisis with so many physicians from their own mental health. Like you said, the repetitive stress injury on physicians, moral injury, as some refer to it. But if we don't focus on this, I think there's really risk of losing. We already have lost so many colleagues, just the stress of the injury and repetitive injury and the experience in COVID. But even beyond, what happens to healthcare when physicians aren't there? We know that's not a good story. It's not a good ending, and it's already happening in certain parts of our country. So I think that is just critical, almost really existential if you're thinking about the existence of physicians.
Now, what are your thoughts on, you say lessen the burden on physicians, okay? You bring technology to lessen the burden on the physicians. What do you think about when the physician doesn't want that burden to be lessened because they're so ingrained in doing things their way? That's the way I've always done it.
Yeah.
You just can't get out of their own way. For example,
Right.
let me give you an example of one, okay? Herb had this brilliant idea of, we should send videos to the patients before they come in for their checkups to explain what's going to happen, give them all that anticipatory guidance, tell them what vaccines they're going to get, the side effects of what they're going to give, send it before the visit, short. And when the patient comes in the room, you ask them, did you see the video? Did you watch the video? Do you have any questions? Then you could do a little bit of just talking about different things, 1 or 2 statements just to make it look good. What do you do about that when the doctors have that, yet they don't want to use it? Because they have to do their spiel.
Right.
I saw so many patients. I'm behind schedule. I went home really late because I had all these checkups. It's like, it blows your mind.
Yes. I think that comes back to that point I was making earlier about teaching. We need to teach doctors to be change capable. When I learned about that, I started thinking, gosh, I teach Northwestern medical students pediatrics in my office over the course of the year, several students. I'm going to talk to them about that. And generationally, it might be easier for them, but to help them understand, be ready for change. This is, you've seen it in your lifetime. You're going to see a lot of it in your lifetime in your career. But that's really what you have to do is you have to change the mindset. And it's so hard to change a mindset. But once you can get past to changing someone's mindset, then you can change their behavior. So you have to figure out, like in the case of your videos, what motivates them. It's motivational interviewing, right? With our own partners, just like we do with patients. Like, what might be good about change? What might be good about changing what you do? What would it take to get you from not using these videos to maybe think about using it with some of your patients? Maybe the infants, for example, that take more time, and just going through that process. And we do it with our patients all the time, but I think our colleagues need it from us, those of us who want to change.
Now, speaking of students, that's another topic. Do students help you or do they hinder you?
You have to figure out your system,
How do you
right?
listen? Yes.
Before I had a scribe, I would say students did help me because they went in to see patients I know. And when I'm seeing patients, I need to gather the information and learn what's going on for the things they want to hear about. But I'm totally fine with someone else gathering that information, sharing it with me, going in, examining my patient, and answering what are really their most pressing questions, right? Because really, what is a checkup about? We should ask our patients, what do you hope to get out of the visit? And that should be our focus. So for me, I have a full schedule. So when I have a student, while they're seeing one patient, I'm seeing the next. They see one, we alternate through the day. So no, but I have to say, I have Northwestern medical students. I don't even know what it takes anymore to be able to get, except they are really talented students. So not a hindrance, and I enjoy the teaching.
But if you try to get a physician to take a student, oh no, they're going to slow me down. They're already slow to begin with, but they're going to slow you down. And I also think it's a generational thing because our crew, we learned to walk and talk to me while walking down the hallway because you're too busy to sit down and discuss. I've seen some of the physicians that tried to have students. The student sits in the corner and listens. Then they'll go to a desk and they'll go onto Google and they'll say rheumatic heart disease. They'll look it up. And then the doctor will just basically read off of the screen and talk to the student and lecture to the student about, is that learning? I think that's pure stupidity.
That's a whole other conversation.
Yeah.
So I'll push back because I know you both like to have students. I don't like to have students. When I'm seeing patients in clinic, I don't want any distractions. I'm seeing patients in clinic. That's my job. I don't want to be distracted. When I'm teaching, which doesn't happen anymore, but I want to have the time to teach. And the old fashioned, which doesn't happen anymore, where there was actually pediatric teachers who you went, you saw the patient, you came out, you told them what you said, what you saw, what you heard, what you asked about, and then they went in with you and they showed you how to do the physical exam properly and what questions you missed. And then they went back out and they were geniuses. They knew everything. I don't know. I was just a medical student, but I thought they knew everything. And they would go over the differential diagnosis, different treatment options, what to worry about, what to communicate to the parents, what to communicate to the nurses. In the low payment arena that pediatricians live in today, you just can't afford to take that time to teach that way. You just have to keep seeing the patients. As far as the public health crisis, I think it's here, Susan. I think it's in Northern Virginia, it's in Chicago. And not only primary care physicians, but for example, in Rochester, the pediatric endocrinologist is taking 8 weeks to take a new diabetic. If you're an adult with diabetes type 2 in Northern Virginia, you have a 6-month wait till you see an adult endocrinologist. If you want an adult primary care in Northern Virginia, you better pony up $3,500 a year because they're not taking new patients if you're not concierge. And in New York and Massachusetts and Virginia, practices are failing and they're just closing. And pediatricians that did really great work are just saying, it's time for me to retire. I don't want to play this game anymore. And they don't sell the practice. They don't give it to younger doctors. They just close the practice and they move on because it's too much work and nobody wants to do it. And the younger kids have so much debt. There's no way that they can go buy practice and make the money. And they're scared that they won't be able to manage it. So it's a big problem. But that's a whole other topic. And then if we're trying to change something in the pediatric office, seems to me that it has to integrate into your electronic medical record. Otherwise, that's another barrier to change.
That I agree. I think that is just fact, right? It has to be that way. It makes no sense to complicate things. Our days are complicated enough. It makes no sense to complicate things by not having integrated tools. But unfortunately, especially if you are going to launch a tool that's relatively new that most pediatricians are not using, it's going to be very hard to integrate it. In my personal example, we are on our big children's hospital's community instance of Epic. And that, what happens and what we can add and what we can add, simple things. We have a good relationship. We have our own dedicated analyst. We can make those changes. But if it's something that's a substantial change, it goes through this governance committee, and that's made up of some of our own physicians, but physicians from other independent practices in the community. And if it's something that's not a priority for them, it's not going to happen. And so we do have the experience and the challenge of having to do our best to choose tools that as effectively as possible can layer on to our EMR where it feels like it's integrated, even though it truly isn't. But I think the reason integration into the EHR is so important is because the EHR, it's not just the chart anymore. Like George, you were talking about the paper charts earlier, and
Right.
Our EHR is not just a replacement for a chart that holds some information for the doctor. It's our connection to our patients. It's our communication tool for everything related to the patient. all the members of the patient's medical home, everything related to what we would call the back end, revenue cycle management. And yeah, it makes no sense to me not to have our innovations of care reside in that same place. But I think that's a big challenge that we're all up against right now, regardless of what EHR. And the way EHRs are built is that sometimes I picture it, think about like those rubber band balls that can get so big, you just keep putting more and more rubber bands. I picture something like that with Band-Aids, right? Like we have this basic out of the box structure and we're like, oh, that doesn't work. That doesn't work. That doesn't work. And we just keep putting these Band-Aids one on top of another. And I think we really need, it's like disruptors, right? We really need to rethink, okay, we're headed into 2024. What does an EHR look like that's functional for pediatrics or functional for some other specialty of medicine? And try to think about building those from the ground up as opposed to just continuing to modify something that is really broken in a lot of ways. And eventually we get rid of those old cars, right? And we start new. And
Yeah, but it's
I
hard
hope
for
that
a
happens.
company.
I hope that happens in my existence and practice.
Yeah, but it's hard for companies like that to do such a thing. They're already late to the game, 15 years. How do you change people to, why would anybody that has an operation going that's big change to a new EHR just because it's shiny and new?
Right.
It could be
But it,
good. I'm sure there's a
yeah.
company out there that's developing a new EHR, but I don't know.
And we like our
Yep.
jobs, right? Like when it comes to advocacy, when it comes to development, all of these things that we could be very influential as pediatricians. But at the end of the day, most of us just want to be in our offices seeing patients. That's what we love. And that's what we signed up to do.
Yeah.
Yeah, the other side of the coin in there is if you're an EHR that it's already established, doesn't say Epic, to undo that coding and rebuild it from the ground up costs millions and millions of dollars. And no one's willing to pay for that investment. And,
For sure.
that's what they say. Yeah, I can
Right.
integrate the fire
But-
standard. I could do this and I could do that. But that's $50 million in development and coding.
But-
Who's willing
but
to
there-
carry up the money?
There is a lot that Epic can do, for example, that we don't have access to. And so when you have Epic and you're on a Community Connect instance through a hospital, you only can access as much as that hospital is willing to turn on. That's really one point of effecting change, is really working with the people who are the decision makers closest to you as the physician on the EMR.
Yeah, I've told George this before. I think the ideal EMR would work very much with a combination of voice and AI to help you take
Ah.
notes like a lawyer does. So if you ever had the unpleasant experience of sitting in a lawyer's office, they write everything down on a yellow pad still, all their notes. And then once you leave, they sit down and they write a letter, hopefully just a letter. They don't write a brief for court. But they have a yellow pad that's where you just take notes. And I think that's the ideal for an EHR, is a yellow pad for the doctor to note down the important stuff. And then it converts into a formatted letter that has all the disclaimers and this and that. Because really, when you go into the exam room, what you're doing is trying to summarize the data in front of you and give the
Right.
parent an answer and give them an action plan. And that, I think, is the very basic essence of what we need. We need a yellow pad to begin with. It can be misspelled, disorganized. Everybody's got their own disorganization, especially me. But then I can convert that into what I wanted to be, the official letter. And that was how we did things before. You noted down a few things in the chart. You walked out, you went to see the next patient, then you came back to the chart and you said, you completed whatever it was, did the bill, and send it off to the front desk. All these templates with little boxes and pop-ups and things, they're just distracting me from the work I want to do.
Yeah, I think I know the EHRs you're on work very differently than mine. I don't even think pads. I think like I really like working with a scribe. I just like to go in the room and talk to the patient. And ask them what's going on, give them my advice, examine them, have a plan, and know that having had that conversation and having been present in that room, what mattered that was important is going to be recorded and not typing, not writing. And like my style with my scribe actually is to walk out and say, look, this is pediatrics. Most kids have normal physical exams, right? And so that's one of the things I talked to them about in the beginning. So when I come out, I say, these are the things that need to be noted on the physical exam. I know he's great at recording the history and the conversation. And make sure you have these things in the plan. Done, on to the next patient. And if you want to talk about efficiency and effectiveness and physician well-being, I cannot think of a better way to do it, at least not right now with the structure and tools we have.
Well, we'll get to that in a little bit. And then one that I think will rub a lot of my physician colleagues wrong. All of this has to make money for me.
Yeah, being in business and talking about our practices that we own as a business is not a bad thing. It's not a bad word. We shouldn't be embarrassed by it because, frankly, if we didn't do well, we wouldn't be here to serve the children and take care of the family. So to me, good care means good business. Effective, high quality care model is part of a good business model. And achieving that means that the money will follow, assuming there are still insurance payments for the work that we do.
Yes. And there, I would push back a little bit against you because you're a little too humble. But if you don't have an excellent revenue cycle management and collections team, you are in a boat that's taking on water and it's going to sink. Your quality might be the best pediatrician in the whole darn world. And there is not a tight revenue cycle management team behind making sure that boat doesn't take on water, you're going to sink.
True. I'm not going to disagree with that. But thank you for making me recognize that I probably am taking for granted the excellent quality of the revenue cycle management I've had throughout all my 30 years in practice, even before we were part of forming Pediatrust.
Yeah, it makes a huge difference.
Yeah.
And so you really like your virtual scribe. And what I understand, there's a good case study of implementing change. This is a real human being. So how does this work? Because he's not in your...
Yeah, it's great. So I've done 2 iterations of scribing. In COVID, we were doing so much more telemedicine, a ton of telemedicine, right? There was a time where we were seeing almost everybody first on telemed. So when I was doing telemedicine, I tried out an actual AI scribe and it was amazing. Again, your conversation is happening and then AI is programmed through its machine learning to produce a note in the style of note that I would type or produce myself. So that was great, but it was really limited to just giving me my notes. And so much more happens for me. So what a virtual scribe is, it's a traditional model of a person who's there, they're listening, they're putting everything together for you. But you don't get just a note. I can say things like, hey, my scribe's name is Max. Max, can you do me a favor? And can you put in my instructions for whatever, fill in the blank in the after visit summary? Hey, Max, can you go ahead and, so we don't forget at the end of the visit, can you go ahead and pen a refill for these medicines for me? Or do you mind putting in the order? So I'm examining the patient and he's putting in the orders for whatever tests or labs that I want ordered. So having a scribe be able to do those things for you is very efficient, very time consuming, and really something that I don't think we need to be doing as the pediatrician. We need to think about what tests do I need to order on my patient to solve this mystery, but not typing away. A person can do more for me and my EMR than just AI as it exists right now. So the way it works is I have basically, so we use as part of our technology, we use Google Workspace. It's like Google Enterprise, BAA, HIPAA compliant. And so we have our Google Meets through our Google Workspace. So I have a standing all day calendar event that repeats between, it's a Google Meet between me and Max on every day I work, and he knows my schedule. And when it's time, and then he is connected in Epic. So he's in the chart as I'm in the chart, he's in my schedule. And when it's time for my schedule to start, we both just sign in to this Meet, and he's there. He's with me in my laptop that I take room to room all day long. When it's time for me to have a break somewhere in the middle of my schedule, we just sign out. He does his thing. I do my thing. I return some calls. We check back in. And each time I come out of a room from seeing a patient, we just have a quick touch base. So I know that he didn't miss something. And then the information that I want to exist in my notes is there. And then at the end of the day, I do review, and it's important to do this. I do review the notes because he's not physically there. He's listening, and he could miss details or something could be nuanced. And that takes me like 1 or 2 minutes per note. So it's very little time. I love it.
If we go through the steps, it improves the patient care experience because you're able to talk to the parents about what's important to them. Your nose is not buried in the computer.
Right.
Like mine is.
People love it. When I'm first coming into a room with someone who hasn't met Max yet. Oh, and by the way, the kids love it. I turn my camera on so they can, like, he waves to them and says hello, and they wave to him and say hello. And then we turn the camera off and go. And so you have to have permission from people to have someone there who's listening and recording and scribing. But yes, parents love it. Like, their face actually lights up when I say, now I can have my eyes up more and focus on you and your child and not type the whole time. Because I was someone who didn't like to have my notes done pretty much by the time I left the room. It slowed me down a little, but then my notes were done.
And it improves your efficiency and effectiveness because you're to work at the top of your license, and Max is putting in the X-ray order and the CBC order and whatever else needs to be put in there so that you don't have to be doing that. You can finish the conversation with the parents. Lessen your burden because you're not typing away and spend, not that you used to do before that, but a lot of pediatricians do, spend 2 hours after clinical hours closing out charts.
But I guess you have to read these things now.
But she says it takes her a minute or two.
Think about your well visits of a child who comes in, they're well, they have a few questions, you answer their questions, and everything else is good. That's pretty templated anyway, right? Yeah, it's just some of the more challenging visits or lengthier visits, but it's quick. It's quick.
Now, does it make money for the practice? Does it mean you can see more patients a day?
Yeah, right now, I don't know that I could see any more patients because I think we're seeing 50 to 100% more patients than we've ever seen for most of the last year and a half. Our charges and patient numbers are just off the wall. They're just out of the park, like unimaginable. So I really don't think physically we could see more, but it doesn't really, honestly, it doesn't matter. So the way the math works out is using a scribe. If I were to see 1 more well visit a day or 2 more sick visits a day beyond average or what I might see without a scribe is going to be revenue positive. So if I just see a typical schedule, and I don't even know what that is anymore, looking at the per hour cost of a scribe, it's just break even. There is no money to be lost on using a scribe. I firmly believe that. You'd have to work in a practice where no patients were coming in. And frankly, I don't think that's the case right now, especially with what we've been seeing in pediatrics.
And you can tell me you don't want to answer it, but what is the cost range per hour for this service?
And I'll tell you, we use a service, like we don't employ the scribes. We work with a company. It's called Scribe. I learned about them from, you guys know, Alana Levine, and I'll give you a ballpark. Let's say that number's between $17 and $20 an hour.
Okay. So I was thinking it would be a lot more expensive.
No. It's just, it is I think mathematically, it is a no-brainer. My colleagues who are employed and show the math to whoever employs you so they understand that you would be generating revenue for them.
Wow. And in your mental health visits, that must be really helpful. And the more complicated visits, That must
Yeah,
be
yes, because those are long to document. Most of us as pediatricians actually do them later after we see patients because you can't do it while you're talking. And then, of course, you're reliving that whole visit. So, yeah, it's beautiful to
okay.
have a scribe.
We'll put the link to that company in the show notes too, in case somebody's interested. And what other you love butterfly ultrasound? So we know that was a big implementation change, and it's turned out to be great.
Yeah, it's a fun tool. I wish I had an opportunity to use it more. I think of it as a tool. I think of it as backup to my stethoscope when it feels like my stethoscope is not good enough to make a decision. But there are so many case uses in pediatrics. I guess it's a conversation for another time. And I really hope this is something that grows among general pediatricians and we have a way to start to train pediatricians to use it. I had to go through the American College of Physicians, and it was really more geared toward adult medicine. And right now in pediatrics, it's very geared toward emergency medicine and procedures and ICUs. But I hope we can develop instruction for use cases in primary care pediatrics because it is a great tool.
Yeah. And then is there any other that you are testing right now that you think is going to be a big hit?
Yeah, I'm not testing anymore. I started out beta testing them, but I've been using for several years an AI tool that measures head shape. And I really like that because it comes up a lot for me in infant visits. And I have a very accurate way to assess patients, to know what to do, and really keep babies who don't need those helmets or orthotics to keep them out of them. That's a tool that's been working very well for myself and several of my colleagues in Pediatrust. Some interesting things that didn't work. We looked at like this home digital stethoscope that a parent was going to be able to use to help us with that barrier of not being able to listen to the chest and telemedicine. Of course, I struggled just to figure out how to use it, and I'm pretty tech savvy. So that tool went by the wayside pretty quickly. We tried out something that was a virtual reality tool that kids could put on to reduce their anxiety around things like shots and stressful procedures. And our patients loved that. It was excellent. But again, to the payments in pediatrics, it was just going to be cost prohibitive. There really wasn't a way for me to figure out an opportunity to get a return on that investment with coding as it is. Love that tool, and our nurses loved it. But again, that one had to go by the wayside. And then something we're looking at now that I'm very excited about, and we would be in the usability phase. It's called Eye Contact. The developers are in Israel. So unfortunately, our plan to launch this was disrupted because the innovator was called up in the reserves as a commander. But this is a tool. So it's a video that children watch. So at the ages we screen for autism, much better than the current screens we have now. And it was validated at Technion University in Israel. But it's a video that children watch of other children. And in that video is an embedded camera. And what that camera is doing is it's recording what the child is watching and where their focus is through the course of this short video. And based on that information, in an incredibly effective way, we are able to screen for autism in the office. So very excited about that. Certainly performs better than, say, the MChat R, which is what we use now. And I think what's most readily available to us as pediatricians. So more to come on that one, but sad for very sad reasons, right? A war that Israel didn't want. We are a little bit held up with that one. I really hope that things end soon and for so many reasons, and then we can move along with that.
So would you do that at 18 months and 3 years, or just 18 months or sooner?
I think we would do it at the recommended times, right? So the recommendation is to screen twice between 18 months and 2 years currently. And what I do in my own office is we do a 21-month visit. So we screen at 18 and 21 months. So we would probably do the same, or maybe it's so easy. Maybe we would do 18, 21, and 24. Yeah, we'll see.
Okay.
But we really
Okay.
wanted to understand what the experience was like, as we said earlier, for patients and our nurses, and to see how we could integrate that into our flow.
And how about these digital otoscopes where you just put the little pen in there and you look at the ear? Is that
Yeah,
done?
I tried out a bunch of those. There was one I was using. So my experience with that, Tylenol even has one now that they've been pretty heavily, I think, marketing to pediatricians. I have a sample of it. It didn't work that well for me. Maybe it works better for others. The problem with those is that parents have a hard time getting the right view. We need a tool that is just doesn't fail a parent's ability to get it all the way into the ear canal and get an image of the tympanic membrane. We know from teaching medical students, right? Sometimes they don't even get the otoscope in the ear far enough to see what we need to see. So I don't think any of those tools are ready for prime time, but I had a lot of fun playing with the ones that I had. And when you know how to use an otoscope, you can get incredibly beautiful images of tympanic membranes.
And how about digital stethoscopes for your use, not for the patient use?
Yeah, I don't have one. I have a resident in my clinic, I think, who I noticed was using one. But yeah, maybe that's next on the list. I haven't been as excited about that. I like my current stethoscope.
Yeah.
And then how about the use of dashboards? What role do dashboards use both in improving clinical outcomes and making sure that you have a great revenue cycle management?
Yeah, I mean, I think what you're really asking is, how do you evaluate what you're doing? So many people think they're doing great or they're doing well or they have this amazing practice. And all of a sudden you look at some of your performance indicators and recognize maybe we could improve there. Dashboards we are not using specifically to look at our tech adoption and what that brings, but we do have a data analyst. We have a lot of different reports we build that we monitor on a monthly basis, on a quarterly basis. We develop goals for our managers every year of all of our different business units. And we put out, essentially it's a dashboard, but it's like the report cards of how they're doing. Every week, we look at visit reports. How are we doing with recall and bringing patients in and how many of our patients that are due for visits have actually been seen? So we monitor a lot. We don't have it all under what I would call one dashboard, but we have these suites of reports and they're all on an kind of automated set schedule of time where they show up. So we get used to knowing what we're going to see at different cadences over the course of either a month or a week or a quarter.
Yeah, I think it's one of the most difficult things to tell pediatric CEOs or managing partners. You don't have time to go through a ream of spreadsheets to figure out what's working and what's not working. There's so much other stuff to do. And if you don't know,
need the summary. You need someone to put it together and give you the summary.
Yes. And the smaller, so a small practice with 2-3 doctors is not going to be able to afford a data analyst. It's just not possible. You couldn't do it. So that's a place where if you can get that service on rented as opposed to buy the whole person, it works. And then you know what you're supposed to be looking at, which is also important. There's so much noise. You need the summary and you need to know what that KPI means. So if you don't understand that, you can't make decisions. And
one thing to think about too, like some of the technology we've adopted for business things, that simple things like voice over IP phones, right? We have the same system across the whole organization. Many of these tools, because they're sophisticated, they have this information built into them. Like how many pediatricians know what their abandoned call rate is? You know, how many times does someone call their office and they hang up? How long does it take? What's the average amount of time that it's taking for a call to be responded? How many calls are coming through your office today? So sometimes investing in a service to provide a function that's critical to your office, but using technology is also an excellent way to give you this dashboard type of data.
Yeah.
A lot of these programs, like we have a very sophisticated phone system with our call center, and it gives you all these reports. What are they? Spreadsheets. Ask me if I've ever looked at it.
Yeah, because you don't want that. You want what Herb's saying. You want to be able to push a button and say, show me my abandoned call rate for this week, or tell me, what the average wait time for a call to be picked up, or ring timer. I don't know what it's called because I don't have to track this. I know we can. My manager shares this with me, but those are things that can be done more easily probably than someone sending you a spreadsheet. Of course, who wants one more spreadsheet?
More spreadsheet.
And there's usually reasonably a question about how to hire a biller. And my first suggestion is hire somebody to hire that biller for you, because if you're asking, I already know there's a problem, and who knows where the problem is. Is it in your front desk? Is it with your process? Is it that people aren't following up on your claims? Or as the business owner or leader of the practice, you simply don't know what to put on that scorecard for people to be successful. And if you're a solo pediatrician or 2 or 3 person pediatrician, do you really have the skill set to hire the right person for the right job?
Right. And I do think like not having the skill set or not knowing how to find the right person, I think there are a lot of easy and not expensive to use tools for both business function, but also for patient experience. There are ways to do digital check-in that's not very costly. There are digital apps for after hours calls instead of relying on people and call centers and answering services. You can do things like we have a really robust patient portal. So if you have a robust or pretty decent patient portal, you can we do 100% adoption of patient portal so that you use it for communication, photo sharing, self-scheduling, like whatever lab report notification, whatever it is that your portal allows. If you require 100% adoption, you say, if you're going to be in my practice, you need to do this, then you're going to get all this function without having to have a person who's expert. There are ways to have live chatting with your schedulers. Patients love that. They don't want to deal with phone calls. You can embed on your website things that allow patients to text the doctor on call. And it's not really a text. It comes to you as a notification with information that the parent's trying to reach you, but just completely bypass services. So that was one of the points I wanted to make is there are ways to save money, not have as many employers, not need expertise in an individual by using some tools that have been out there for a long time, keeping documents in DocuSign. We moved our whole business office. We are 100% paperless, no files of anything that aren't electronic. We use e-fax in our office. It's easy to receive electronic faxes. Then you're not paying someone to deal with all the faxes on the fax machine. They go right to the place they need to be in the chart server. So these are some of the things I think are worth thinking about too, not just patient care.
Yeah. So a lot of areas for implementing change.
Now, I'm curious with the patient portal. Patient portals have been around now for a while, yet they seem to be failures in a lot of practices. Why is that? How did you get 100% agreement on this? How did you change the culture?
To be honest, COVID helped, but it was a goal before. So what do we do? Remember, I said we have goals for our managers and they're compensated based on achieving their goals. And we set a level at which those goals need to be achieved by the end of the year. So part of it was setting his goal. Part of it is having a dashboard or a way to track how we're doing, to know. A lot of people are like, oh, we're doing great. And you look at the numbers like, well, you're not doing so great. So really having that data, analyzing what you're doing. But when you say to patients, this is what we do. This is how I want to communicate with you for X, Y, and Z. This is how we will not be calling you about your strep test results. If it's positive or negative, you're going to get a result in the portal. And if it's positive, you should expect that a prescription will be sent to your pharmacy. So we don't keep people in the office waiting for test results. We get them out and they learn. And I think a lot of it was wanting to know those COVID results that got many people trained to just get on the portal. You have to teach your staff how to help patients do it. It doesn't help if you have someone sitting at your front desk and they're like, yeah, I don't know how to set that up. And then you just do. And there's always a little pushback from patients too with change. When you implement something new, you're going to hear from the patients who don't like change, not just your doctors and nurses and patient representatives. But it takes about 6 months. And once you say, we made this change and we're sticking with it, we like it, people come around and you stop hearing about the resistance. People adapt.
Well, and then you have an executive coach, right? Why is that important?
Yeah. I mean, I have started working with individual coaching really recently. It took me a long time to get to this place. And in part because there's an expense associated with it. And I'm very aware of how much of a practice's money I should be spent on me. So I started out doing a lot of reading, Then that became podcasts. That was my own personal learning. I had participated in network groups, networking with women for many years, and especially early on. And I considered those individuals my group coaching at the time. But because I'm transitioning to a new leadership role, I started using that coaching to really prepare for the change for me and how to think about my goals in some of that work and really to learn at a deeper level some of what we're talking about today, how to take this really awesome team that we have through transitions, because transitions and change are hard.
And then the difference, you're, if I understand it correctly, you're right now in a one-to-one coach, which is a little bit more expensive. But if you're a smaller practice and you can't afford that expense, a mastermind group of like-minded individuals will give you a sounding board and somewhere to go solve problems together, which is what you were doing in the past.
Yeah. And that was an unintended consequence of originally our 7 practices coming together in Pediatrust. Is we called it a brain trust. That was our term instead of mastermind. But we recognized that we brought this group of doctors together, absolutely like-minded, which is how we've been able to do so much. But there were so many different areas of expertise among that group. And I think that's really what helped us build such a great practice.
So
And I think that's incredibly, incredibly helpful way to do it. And I want to say something else, like whether it's coaching, whether it's a mastermind group, whether it's a networking group, accountability is very important if you're going to get involved in any type of coaching or growth or building your growth mindset. And so it's not just about showing up and gathering ideas, but it's really about committing to do something and then making that work happen. So I think it's really important to emphasize that accountability to change is a big part of that.
Absolutely. And I think the other piece is what you say very nicely is no one can be great at everything. And a pediatric practice is a very complicated animal. There's some excellent clinicians that don't want to mess with revenue cycle management. There's some mediocre clinicians that are great at revenue cycle management. There are people that can read spreadsheets all day long and it doesn't bother them one bit and they can figure things out by just looking at them. There's others that can talk to people really well and get people to do things together as a group, but don't want to read a spreadsheet ever again in their lives. And if you get these people in a room with different skill sets, everybody learns and everybody grows. And you can't always do that if you're a smaller group. So you have to find something outside your organization to do that.
And I've had the good fortune just a couple times, but seeing both of you do that with some of your coaching work. And I love seeing that in action.
We would love it when you come and you have so many insightful observations that helps us be better. And can't thank you enough for doing that. I think I've exhausted more than an hour of your time. So very thankful, very grateful for our friendship and the time that you give us.
Thank you.
Is there anything else that you want to say to the audience?
Yeah. If I were to give just my parting message, I would say we're pediatricians. I know there are people who aren't pediatricians who listen to your podcast, but I'm going to say we are pediatricians and we can do hard things. I think we know that as pediatricians. And think about it, the two of you as pediatricians. How many times have other doctors said to you something like, oh, I could never be a pediatrician? I feel like I hear that all the time from other physicians. And I think what they're saying is it's hard to be a pediatrician. Change is hard, right? Our brains don't want to change. They hate change. But change is probably more important than ever now in our practices. And we go into medicine. We want to make a difference in some way in the lives of others. But in order to do that, every day we find ourselves asking our patients or their parents to make a change. And we expect, but we believe that they can make that change. So I think we should acknowledge that change is hard. But if we are asking people over and over on a daily basis to make change and believe that they can do that and it would be better for their child, then we have to trust that we can be successful changing as pediatricians, right? If we expect they can do it, then why wouldn't we believe that we can change as successfully? So
You enjoy
I
going?
would say give it a try.
Do you enjoy going to work still?
She
I
loves it.
do enjoy going to work. I really
I love
do.
going to
All of the work that I do, I love it. I can't picture myself doing anything else.
Yeah.
But every day, and I've said this before, and I've felt this for a long time. Every single day that I go to work and see patients as a pediatrician, I come home and there is always at least one reason why I know it was very important that I went to work that day. Something happened and I know there was a reason I went to work. And I've never done any other job, so I don't know if there are other careers and other work where one would feel that way every day they came home. There probably are, but for me, that's something that's so important.
It sure beats manual labor and internal medicine, because all my internal medicine friends are all miserable.
Yeah. So pizza's hard, but we're happy, right?
Yeah, we're rock stars.
Well, to wrap it up, I just want to wish not only Dr. Sirota, but the whole audience that 2024 be a year where we learn to change and that the whole world, not just us individually, find peace. We need some peace. We need to get along better with each other. And hopefully that will happen in 2024.
Yes, that's the great wish for the new year.
Thank you. Physician Computer Company. PCC empowers independent pediatricians, streamlining daily operations and improving financial stability. A trusted pediatric partner for 40 years, we offer award-winning support, personalized training, seamless data transitions, and practice analytics. With inclusive pricing, a lively peer community, and a free annual users conference, you can focus on what matters the most, your patients. Explore more at pcc.com. That is pc.com. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.